Welcome to ASRS's Journal of Vitreoretinal Diseases Authors Forum. I'm your host, Dr. Timothy Murray, Editor-in-Chief of JVRD. On each episode of the JVRD Authors Forum, I will interview innovative retinal researchers on their studies featured only in JVRD and how these studies will impact our patients' care in our clinics. Tune in to hear directly from investigators about the clinical implications of the newest and highest quality research in the field of retina. Welcome to the Authors Forum of JVRD with our podcast today with Dr. David Boyer from the Retina Vitreous Associates Medical Group of Los Angeles. We're going to talk today about his recent paper, Real-World Outcomes of the 0.19 milligram Fluocinolone Acetonide intravitreal implant for diabetic macular edema. Welcome, Dr. Boyer.
Thanks, Tim. Thank you for having me. I want to give credit actually where credit is due, and that's to Christine Morozova, who actually is in college and was really one of the senior people, and Firas Rahal, who I think was the instigator behind this. This is an interesting trial because I think we all have seen clinical trials done by drug companies. This is a real world trial. This is what we do in our clinics every single day. And we all know that basically when we look at the diabetic patient, we know that even with monthly anti-VEGF injections, we're unable to completely resolve the edema that's present, and we probably leave some vision on the table also. So this was an attempt to try to find out what happens when we use the fluocinolone implant. So basically, this was a group of patients. There was approximately about 148 eyes of about 115 patients. We ended up with 94 who met the criteria of having 1 year information prior to the fluocinolone implant and 2 years of follow-up. So this was not just a short look at 1 year follow-up, but we actually went 2 years. And it was interesting because I learned a lot in reviewing this because you always remember your last experience with fluocinolone. And we looked at the patients carefully, and we found that there was approximately 4.9 injections in the year prior to using the implant. After, there was about 1.4, about a 70% reduction in the need for additional treatments, which is significant. That means, your patients, don't require injections as often. And that was accompanied with a completely stable visual acuity. And the OCT, which fluctuated a fair amount, but actually got a little better over the period of time in many, many cases. Safety, of course, is probably what we all worry about whenever we use a steroid. They work very, very well, but steroids are associated with cataract, and they're also associated with increased intraocular pressure. And certainly, we did find increased intraocular pressure. Very few patients went above 30. We had patients that went above 25. About 30%, 35% of patients required additional anti-glaucomatous medication. However, the need for cutting surgery or even laser was very, very small. So we had about 6 patients that required some type of interventional glaucoma surgery, one of which, had rubeotic glaucoma, which I'm sure that the steroid's not going to be able to take care of. The other had uveitis. And then there was one patient who had a laser. So overall, we found through this investigation that this form of therapy was relatively safe. You have to be very careful. And certainly I think that, you pointed out at meetings that, you can minimize the complications by just having the patient on a steroid prior to make sure you don't have a steroid responder. And you can reduce keep the vision good with much, fewer injections over a period of time. So it was exciting for me.
So, Dr. Boyer, I find that fascinating because you and I do have busy clinical practices, and real world data is often so different from clinical trials data. How did you select in particular which patients you felt were appropriate for fluocinolone?
Well, I think, whenever you do a clinical trial for a drug company, the the reason you're doing it is to get the drug approved. So you are going to limit who you put in. You're going to have strict criteria. This was more real world, but in saying that, you have to realize we wouldn't probably put this in a 35-year-old patient that's phakic with a clear lens, because we know that they're going to end up, having their lenses removed. We may be hesitant, or a patient who has glaucoma. So I think you reduce the number of patients that probably could benefit because of the potential of causing glaucoma. We reduce those patients.
And I think the comment you made about having a steroid challenge so that you can make sure when you look at these patients that at least they're not an obvious steroid responder. So I do think that the phakic status is one that we look at, and I think we look at, what their pressures have been and what they need to be. So I think those are sort of critical parameters in the clinical trial. I also find it interesting, there's been lots of discussion, and I know you and I have talked about this, that anti-VEGF targets one arm of that diabetic cascade, but steroid has such a broader application beyond just its anti-VEGF effect. So did you consider using a combined treatment modality for your patients where you give them fluocinolone acetonide and you continue to inject an anti-VEGF?
Well, most of the time that the patients received a rescue, in other words, that they showed either an increase on the OCT or they showed a decrease in vision, they received an anti-VEGF. But you're 100% correct. And it's very important to point out that steroids have been shown to be highly effective. We know, even going back to Protocol I, when we looked at some of the early studies, if you eliminate the patients who developed cataract and just did the pseudophakics, the results were almost equivalent to the anti-VEGF. Obviously, as you point out, and I mentioned, the pressure is always, a potential problem. But I think that we will continue to treat. Additionally, that 1.4 injections per year was not another steroid necessarily. It was usually an anti-VEGF.
Correct.
And I think that you're correct. These ICAMs and other cytokines that are playing a major role here are not treated with the anti-VEGF treatment. So a combination of some form anti-inflammatory would be extremely helpful.
So in this world where we have these extended duration drugs, what role do you think a steroid plays for those patients? Do you still think it's important to suppress that inflammatory component while you decrease anti-VEGF? What are your thoughts on that?
Well, I'm really happy to say that, we do have longer acting drugs today. We have drugs that are, have two modes of action, in the form of faricimab. And I think that's great. But I still think, even despite this, and even with frequent injections, there's still a group of patients that don't do well. And I think that we need to identify those people. And it would be great if we could measure cytokines in the anterior chamber somehow, non-invasively, find out who's at greater risk. I do feel that you can identify some of these patients much earlier than we do. A lot of people say, well, I'll give 6 or 7 anti-VEGF injections, and if it doesn't work, then I'll go to a steroid. Well, there may be a place, if you don't see a big response at all in the first 2 or 3 injections, to immediately add a steroid. It doesn't mean you're going to stop using your anti-VEGF. It's just that you may need that extra boost from, reducing the inflammatory component.
So when you look at a steroid supplement, we have another steroid, Ozurdex, and then we have the fluocinolone acetonide. They have different functional deliveries of steroids. So how do you choose, or is this really your primary approach to steroid suppression?
Well, you're 100% correct in that we have many choices. We have, we have Triessence, we have Ozurdex, and with fluocinolone. Fluocinolone can last 2 to 3 years, which is a major advantage. Unfortunately, though Ozurdex, when we wrote the paper, it was 6 months, every 6 months. The drug doesn't last that long. It's a 2-month drug on a good day, and it can be shorter on a bad day. So I think that, I look at it very carefully. Again, going back to what we spoke about, if the patient's phakic, they have a clear lens. I could get away with 1 Ozurdex injection, they won't develop a cataract. But if I start going 2 or 3, then suddenly they're going to develop a cataract. And I think that all the steroids that we have are additive to what we have. I still think anti-VEGF is able to get 40% of the patients dry as a bone, but there's 50-60% of patients that don't dry out totally. And I think that's where we have this place of steroids, where they really will impact, hopefully, the vision and the overall well-being of the patient.
Well, Dr. Boyer, thank you for your team and yours evaluation of real-world delivery of steroid using the fluocinolone acetonide implant. I think that's very important. You and I both agree these are some of our toughest diabetic patients. So I want to thank you for sharing your expertise with us, and thank you for spending your time talking with us today. Thanks for tuning in to the JVRD Authors Forum. You can watch and listen to more episodes on the ASRS YouTube channel and on popular podcast directories, including Apple Podcasts, Google Podcasts, and Spotify. Visit www.asrs.org/JVRD forum on the ASRS website to learn more. See you soon.